and also thank AbbVie for sponsoring this meeting. I've been asked to talk about the role of biomarkers in managing IBD, which is a very big topic, but I'll try to touch on the most important things for the sake of time. So these are my disclosures. The objectives: we'll quickly talk about the natural history of UC and Crohn's and consequences of inadequate treatment. Then briefly discuss the relevance of mucosal healing, and then talk about the role of biomarkers in managing IBD, as well as some future directions. So this is the famous Crohn's disease diagram that we see in every meeting that gives us a good idea about how progressive this disease can be, especially if it goes untreated with time, and how this delay in treatment can lead to complications and ultimately to surgical intervention. But we shouldn't forget that ulcerative colitis also can be somewhat progressive, and if patients are not treated well, about 20% end up requiring colectomy within 25 years of follow-up. With time, we've observed a decline in this chance of requiring colectomy. As you can see here, over the past few decades, the risk of colectomy has declined, and we attribute this mostly to the introduction of effective treatments, mainly biologics such as infliximab and adalimumab. And you can see on the left side the Kaplan-Meier curve estimates that show us a very good separation early on in the course of the disease. Of course, these biologics have proved to be very effective. We have robust data from large landmark studies that are RCTs, such as ACT1 and ACT2 for infliximab in ulcerative colitis, where we've seen a very significant probability of mucosal healing in both of these cohorts, which has been associated with prolonged remission within long-term follow-up, as well as with adalimumab from ULTRA-1 and ULTRA-2, especially in those that respond within the first 8 weeks of treatment. This has led to the introduction of a treat-to-target approach, which has been discussed already by Dr. Nahla, and is pretty much now the standard of care in our management of IBD patients on a daily basis. But the tricky part is choosing the target, especially a target that can be used and is feasible. Of course, we know that our patients that present to our clinic who are symptomatic can be symptomatic due to many causes, such as IBS, lactose intolerance, food intolerance, infections. Bleeding that we see sometimes can be due to outlet bleeding from hemorrhoids, and there's also other inflammatory conditions that are associated with IBD, such as microscopic colitis and celiac disease, as well as thyrotoxicosis, and finally active disease. So not every patient that comes to clinic that is known to have IBD who is symptomatic has to have active disease, but we actually need to reach that conclusion following a thorough assessment through history, physical exam, and ultimately the need for endoscopic assessment. However, it's also important to consider that symptoms in IBD don't always correlate with disease activity, especially in Crohn's disease. We know from repeated data sets that patients with Crohn's disease can be symptomatic but not have much of active disease endoscopically, and vice versa, as you can see from this nice diagram that correlates CDAI scores with CDEIS scores on endoscopy. So it's true that endoscopy is the ideal and optimal way to assess our patients. It's considered the gold standard, and we use it to diagnose and evaluate patients with IBD. However, it's costly, there's limited availability, long waiting time, and of course the theoretical risk of perforation that limits our ability to use it judiciously with our patients whenever needed. Therefore, non-invasive methods to assess these patients are required, which is where biomarkers come into play. So just to define a biomarker, it's a characteristic that is objectively measured and evaluated as an indicator of normal biological processes pathogenic processes or pharmacological response to a therapeutic intervention. So in other words, it's really a surrogate measurement of a target condition. There has been many biomarkers studied in IBD patients from the blood and from the stool. For example, in the blood we have seen CRP, ESR, vitamin D, and numerous antibodies such as ASC and ANCA used over the years to evaluate patients with IBD. In fact, there's so many biomarkers in the blood that have been investigated as reliable biomarkers, but the majority of them have been found to be of limited clinical use. So the two that I'd like to talk about briefly, number one is C-reactive protein, which everybody uses probably for many years now. So CRP activates complement by opsonizing apoptotic cells. It's synthesized in the liver, and it rises rapidly after any inflammatory stimulus. Concentration above 5 can be seen at 6 hours and peaks after 2 days. The half-life is about 19 hours. And as expected, it's influenced by pro-inflammatory cytokines such as IL-6, TNF-alpha, and interleukin-1 beta. It falls rapidly after stimulus for increased production. There's no diurnal variation. It's not affected by meals. It's not specific to a certain disease. But more importantly, to remember that 20% of the population do not produce CRP. The new kid on the block, serum calprotectin, which has been investigated recently and has been proven to be of good prognostic value. It's been studied to predict response to and relapse following anti-TNF agents. It has a very good profile that is similar to CRP and can be used in conjunction with fecal calprotectin to predict relapse after anti-TNF withdrawal. As you can see here from this recent study, the hazard ratio of 2.7 has been calculated with serum calprotectin as a predictor of aggressive course in patients with IBD. Here you can see in IBD in general and in Crohn's and UC, it has been proven to be of prognostic value, and I think we'll see more and more of serum calprotectin within the next couple of years. So moving on to the stool, so there's some historically known fecal biomarkers that have been investigated. One of them is indium 111 labeled WBCs, which is considered the gold standard. Very sensitive, however, it's expensive. There's some radiation exposure, and it takes 4 days to collect. There's also alpha-1 antitrypsin and alpha-2 macroglobulin. These are not used commercially. Now, the newer ones that have been available commercially, we have seen and used in clinical practice. The most important one is fecal calprotectin. There's also fecal lactoferrin or stool lactoferrin and S100A12. So we'll focus more on fecal calprotectin because it's the marker that we are more familiar with. So it's calcium and zinc bound protein, accounting for 60% of the soluble proteins in the cytosol of neutrophil granulocytes. It does have both antibacterial and antifungal activity. It really is a marker of neutrophil turnover and is released into the intestine during colonic inflammation when neutrophils die. It's resistant to colonic degradation. It's stable for about a week at room temperature, and we measure it using ELISA. It's also important to know that there are some causes of elevated fecal cal other than IBD, such as NSAID use, cancer, infections, and sometimes bleeding. The other stool marker that I haven't seen much commercially here in the kingdom is stool lactoferrin. It's iron-binding glycoprotein secreted by most mucosal membranes. Again, it's in the granules of neutrophils. It has antibacterial activity, and it can be helpful in detecting inflammation. So some considerations that we should keep in mind when we use biomarkers in clinical practice. Number one, clinical context. I'll touch on that in a minute. Prior readings, pre-test probability of detecting target abnormality, cutoff points, consequences of false positive and false negative results, and some potential causes of these results. So this is a horizontal view of what we could see with a patient that was initially diagnosed with IBD. As you can see at the beginning, let's say, for example, you You start with a high reading of fecal cal, you drive it down to your target normal range, and then you monitor it for any blips or increases, and try to bring it down using adjustments and therapy. What's important to note is that there is a range here in yellow that we labeled as uncertain, and we sometimes struggle to interpret this result when the result is in this range. So it's important really to know the trend in our fecal calprotectin measurements over the past few months. So some of the applications for fecal cal: number one, differentiating IBD from IBS. I won't be talking about this since it's related to a different topic. However, I'll talk about predicting relapse in quiescent IBD patient, evaluating disease activity, post-operative surveillance, and monitoring response to therapy. So you can use fecal calprotectin to predict relapse. It's a useful tool. As you can see here from this study that was published close to 20 years ago, that when you have a low level or low concentration of fecal cal in both diseases, it can mean that patients will continue to be in remission for a prolonged period of time. As you can see here, sustained concentration below 50 predicts maintenance of remission for up to a year, and you can see how fecal calprotectin begins to rise gradually months before the development of flare. So we can look at a sudden elevation in fecal calprotectin as a potential marker that this patient might be heading towards a flare. Having said that, there's not much literature out there on this topic. There's very limited studies that look at fecal cal as a predictor of relapse. So monitoring disease activity, this is where we use our test commonly. So this is a study that we conducted a few years ago. As you can see, the mean concentration is very different between patients when they're inactive and active. And of course, patients that are active have higher concentrations. But it's important to note that disease location matters. Patients that have purely colonic involvement tend to push up their fecal calprotectin levels compared to those with small bowel involvement. Now, it's important to understand the operating properties of these tests. As you can see, in this context, which is completely different than patients at the time of presentation, you can see that fecal calprotectin is fairly sensitive, but not so specific, with a decent odds ratio of about 20 that goes up when you differentiate patients into CD or UC. And when you compare this to C-reactive protein, you can see that CRP has much lower sensitivity and higher specificity. Of course, predictive value, which is a function of the pretest probability, when set at about 50%, you can see how the fecal calprotectin gives you a very decent negative predictive value that rules out inflammation. And you can use these Fagan normograms to sometimes figure out your post-test probability. Of course, another application is using fecal cal to predict post-operative recurrence. It's now part of many algorithms used for post-operative surveillance. You can see here, this is a really nice diagram that stratifies patients into root-geared score between I0 and I4, and you can see nicely how going up the score ladder, patients tend to have higher fecal calprotectin levels. Here, again, you can see when you compare patients with and without recurrence, that patients with recurrence tend to have higher fecal cal concentrations. And you can use the nice diagram on the right as a predictive model to try and figure out what is the probability of having recurrence using your fecal calprotectin concentration. So what I do now in my practice is I order fecal calprotectin monthly after an operation, between the time of initial follow-up to the time of the initial endoscopic evaluation, between 3 and 6 months. And it helps me decide whether or not to do that endoscopic evaluation earlier than planned. Important note to keep in mind is the cutoff point that should be used with these tests. Obviously, when you go up on the cutoff, so if you choose a higher cutoff, what you're sacrificing is your sensitivity, but you're gaining more specificity. So when someone asks what cutoff point should I use, it really depends what is more important to you. Do you care more about jeopardizing a false positive or false negative result? So you can use those general rules to decide which cutoff point to use. But what I usually go with is 50 when I'm investigating someone that presents for the first time, 150 to monitor patients with symptoms, and 250 for prediction of relapse. For post-operative patients, I tend to treat them as if they started from the beginning and they're disease-free at the time of operation. Finally, monitoring response to treatment. You can see here this nice figure that shows you how fecal calprotectin declines weeks following the introduction of anti-TNF. So this can be a useful strategy to follow in clinical practice, which is doing fecal calprotectin, let's say 4 weeks following induction or first dose of induction, and every month thereafter. There are some nice tests coming down the pipeline to monitor patients as biomarkers, So metabolomics, which is the investigation of a group of endpoint metabolites of a physiological or a pathophysiological process. So metabolic profiling can be useful as means of differentiating IBD from other diagnoses and differentiating CD from UC. Specifically, volatile organic compound is becoming a hot topic, and we'll be seeing more publications about this hopefully in the future. There's also gene expression arrays using microRNA sequencing, and finally proteomics, which is protein profiles in the tissue, serum, or stools, that is also being investigated as potentially useful tools that can be translated into clinical practice. So in summary, mucosal healing is an important endpoint of treatment for IBD. Monitoring IBD patient symptoms is not sufficient. Performing routine endoscopy is probably resource intensive. Objective measures of disease activity that are safe and readily available, such as biochemical markers, can be used for this purpose. Clinical context is very important, as is pretest probability, and should be considered while interpreting results of biomarkers. Thank you very much.